We're really fortunate we've got two very experienced speakers here for us this afternoon, both clinicians. We have Melissa Kent from Partners in Recovery West Moreton-Oxley and Suellen McCurley from Ipswich West Moreton Hospital Health Services District. Melissa is a clinical psychologist in private practice with DBT Coordinator and a DBT Coordinator at Partners in Recovery West Moreton-Oxley. She has a PhD, she's a PhD candidate at the University of Queensland Faculty of Medicine, and her area of special interest is working with people with BPD and complex trauma. And Suellen is a clinical nurse currently employed at the Community Care Unit in Gales, Queensland, and she's interested in and passionate about helping people with BPD and other complex disorders. Ladies, you are in the right room. Thank you very much. Can we welcome them, please?
On. Thank you. So, Melissa and I are going to talk about the partnership, the connection that Queensland Health have got with Partners in Recovery Floresco in Ipswich. It's kind of been a journey of probably maybe 2 years in getting basically 2 DBT programs running in our region. So there was none. 2 years ago there was nothing. There was no treatment for people with BPD. And so from the hospital health service point of view, I'm going to start off our journey. So we're going to talk a little bit about the Ipswich area. I don't know if anyone's familiar with the Ipswich area. We're going to talk about the West Moreton journey, the NGO journey, and then how we got together and how we're working together. And then what we're offering in the region for people with BPD now, so it's not just the 2 DBT programs, there's a lot of things happening that we've sort of recognised that we need in the West Moreton region, and also from what our consumers are telling us so far. And then what we're going to do in the next 9 months, and then we're going to have a chance for you guys to ask us any questions. So, yeah. So the Ipswich West Moreton region, we cover a huge area. It basically stretches all the way up sort of to Esk, not quite towards Gatton and Toowoomba, but down towards Boonah. There are a number of little sort of satellite hospitals in the area. So we've got Ipswich General Hospital, which is the main one. Have you got more? Can you flick on a little bit?
These are just some photos of beautiful
nice
Ipswich.
Pictures. So, you know, people hear Ipswich and like, oh my God, Ipswich. It's beautiful. It's lovely.
Beautiful old building.
Yeah. And so it is undergoing a massive redevelopment and regeneration. There's a lot of stuff happening in the Ipswich area at the moment with the council and things like that. But there is a core group of people working really hard to just make things better for everyone there. So in 2012, the population was about 252,000. And that's going to increase to about that, to 637,000 by 2036. So it's a massive area of growth in the southeast Queensland. And there's an even distribution of males and females. That's the population by age group. So we've got quite a high number of people between the sort of 16 to 65 age group, and that's the age group that we're focusing on today. So a very high population of people in the lower socio-economic status, and then a sort of even between the high and medium, so it's a fairly disadvantaged area. So by numbers, the HHS, we've got an acute care team, so we caught up with our acute care team leader last week, and she gave us some numbers of how many people go through basically Ipswich Emergency Department from a mental health point of view. So the acute care team have got MH call, they've got ED, they've got consultant liaison, and then they do home visits.
They've got a community team.
Community team as well, yeah. So they cover quite a large area. But the largest referral cohort was basically bipolar affective disorder, but also borderline personality disorder. So the highest population of people that came through ED with mental health issues fell into those diagnoses. And so 40% of the ED presentations were related to self-harm, suicidal ideation, and suicide attempts. So that's a huge number of people coming through. 60% arrive via ambulance, less than 5% via police. So we've got a co-responder role now in the Ipswich area. Did Fiona say it was the only?
It's the only one in Australia.
The only one in Australia. So we have a mental health nurse who goes out, and the shift is from 1:30 in the afternoon till, or 3 in the afternoon till 1 in the morning. And so that mental health nurse goes out with the police, and so she responds, they respond to any kind of mental health crisis or situation that the police have been called out to. And Fiona said that has reduced EEOs by 17% in the Ipswich region, which is just phenomenal. So it's such a good service to offer our consumers. Unfortunately, less than 1% of consumers who come through ED can access the DBT via the community care team. So one of our big barriers to people accessing DBT at the moment, it's a frustration for all of us, is that the HHS consumers have to be case managed, and that's just a clinical governance thing. There's no way that we're getting around that at the moment. And it's very frustrating because all those people go through ED, not every single one of them is going to get case managed. So the need is really well recognised, but we're working hard to try and change that and to try and sort of get these people access to the DBT programme. And I guess that's where, Melissa's programmes come in, which has been amazing. And then obviously as well, we've got like one of the lowest rates of access to private psychiatry. So even the people who come through emergency, there's no one to refer them to from a private psychiatry point of view. I think we've got 2 or 3 private psychiatrists in the Ipswich area, and they're snowed under. So it's really, really tricky. So to start the DBT journey, the CCU, where I work, it opened in 2016. And we're in partnership with Mind Australia, and it's an 18 one-bedroom unit facility for people with severe and enduring mental illness. And we support them over a period of about 18 months to learn the skills to live independently. We're in partnership with Mind Australia, so the NGO, they come and they cover the 24-hour care. And what the health team were tasked with while we were sort of waiting for numbers, waiting to get full, we were tasked with providing therapeutic groups to the West Moreton region, because there actually wasn't any up to that point. There was a few, but they were inconsistent, they were infrequent, staff were coming and going. So there was no groups that were stable, being run consistently. And our clinical lead, she put out a bit of a survey to the staff in the whole of the West Moreton region, the mental health staff, and she asked us to have a think about the therapies that we were trained in, the therapies that we were interested in, and the therapies that we had confidence in delivering. And so the big thing that she noticed was that there was a real lack of confidence, training, and ability to look after people with borderline personality disorder, and that's where she said, right, we need to do DBT. So I think there was 2 clinicians at that point, and that was November 2016, and there was 2 clinicians in the whole West Moreton region who were trained to provide DBT support to our consumers, which was abysmal actually. Along with that, she looked on the Queensland Health mental health CIMA, it's called, the Consumer Integrated Mental Health Application. So that's where all of our data is, and that's where all of the the notes and things are for our consumers. And she did a search for the West Moreton region to see what the diagnoses were. And so the highest population of diagnosis in West Moreton is schizophrenia. So she developed, she did the research, and we all got trained in SCIT and CRT and various other things, but also the diagnosis that came right next to that was borderline personality disorder. So again, that just backed up the need for more of us to get trained and, for a group basically to be delivered. we caught up with our colleagues at the Park Centre for Mental Health in High Secure. They do DBT. A lot of their clinicians are trained. So I actually went and joined them and did, just a little bit of, what's this all about for a few months. But that had its own limitations because it's a high secure environment. So they had to basically just work with what they had. And it was DBT skills, but it wasn't a full program. So at that point as well, there was lots of things happening at once, sort of 2016, early 2017. And so we caught up with our partners at Floresco, and this was before Melissa came on board. And so we caught up with everyone. We thought, how can we work together? How can we do this? You guys have got lots of DBT people, everyone's interested in DBT. West Moreton needs to deliver a program. How can we, as, a whole service, all of these services working in West Moreton, how can we deliver this? And so there was a few weeks, maybe a few months of discussions with Floresco. And again, it came down to clinical governance, so we just couldn't make it work. So we all sort of separated off again. We got trained in West Moreton, a few more people got trained. I got some DBT training, a few of my colleagues did. And we kept on with our consult group. And we started our DBT group last year in September 2017. So we've done a full program now, and that was really exciting. But discussions with Floresco continued, didn't they? So we just sort of, because we could only offer the case-managed consumers, that's such a small population. We're like, how can we get our ACT consumers this service? Because a lot of those guys going through needed it. And then that's where your program came in, and discussions with the acute care team leader, who's sort of saying to us, you can't help us, who can help us? And yeah, so that's where Melissa came in. Over to you.
So then I moved up from Melbourne at about that time, and kind of inserted myself into the picture. Mm-hmm. And so I was working Aftercare. Does everyone know Aftercare? It's like a organisation, and they have many, many different other things that they do. And one of the things they do is Partners in Recovery out at Ipswich, and they had a historical underspend, and they approached me and said they'd done their own analysis of service, and they found that they were supporting a really huge proportion of clients who had BPD, but those clients were using most of the time of staff, not relative to how many, so disproportionate to the percentage of clients that actually, I'm not making any sense. Do you know what I'm trying to say? Yes. So smallish number of clients using the majority of the resources. And they said, there's got to be a better way of doing this. So they approached me and said, would you come on board for 12 months with their underspend to develop a community of practice around working with people with BPD and maybe get a program off the ground. So in that 12 months until July last year, I established the Ipswich West Moreton BPD Mental Health Professionals Network, which we're about to have our first anniversary. We've been meeting for 12 months now. I ran monthly training sessions for support workers because they were the ones who were supporting these people but didn't have much confidence to do that. I did a lot of complex case consultation and started to go and meet people in the region, and that's where I came across Sue and all of the rest of the team. So, and then the health team started attending our mental health professionals network, and we all started to get friendly and try and break down a lot of that cultural divide that exists in most places between health and not. And so we know that historically, as Sue just said, Partners in Recovery and West Moreton tried to establish a joint DBT group, but clinical governance, it just didn't get off the ground. So we decided to try again. So in October 2017, we met and we identified that real gap. So DBT is only available for people who are case managed, but that's not a West Moreton thing, that's across all, so we just kept meeting up, and we were thinking, okay, what about if we both ran programs at the same time? And we figured out that there were long-standing service level agreements between West Moreton and Floresco. That's another NGO that, I'll tell you the story, my position merged into that, that provided the clinical governance and stuff that we needed. So all the groundwork was there. So, yeah, so then of course money runs out. So I didn't have a position anymore with Partners in Recovery, but Floresco, who's another part of aftercare, stepped in and said, we've got a little bit of money, we'll take you on for the next 12 months. So until the 30th of June next year, this position still exists. So what I did was we trained up a workforce. We trained 21 people in the region on how to deliver DBT. We did a 5-day intensive workshop and we've got 12-month follow-up and supervision. We trained a combination of health and non-government staff, and last week we had our first session of our standard comprehensive DBT program for non-case managed consumers in West Moreton. So there's a lot going on in our little region now.
Yeah.
Do you want to?
So, yeah, working together, but also working apart.
Yeah.
So we've got the two programs. So the West Moreton HHS, we had a look at the start, and obviously DBT can go on for 6 to 12 months. As a consult group, we kind of felt that was quite restrictive to our consumers who needed service now, quickly. So what we did was we split up the DBT group into the separate modules, as you do anyway, and we offered a period of intake at the start of each module. So it does mean they're doing it a little bit out of whack, but it also means that they can step in and out of it, and it's actually working really, really well. So, and it just offers, more consumers access to DBT quicker. So it's not just, it's 6 months till the next group, sorry, you can't come. Our consumers kind of needed that, that intervention quite quickly. So that's the way our group runs. And obviously ours is consult group. You guys are doing it a tiny bit differently,
So both our programs, we do the standard 4 modes, which is excellent, and it's all completely by the Marsha Linehan 24-week manual. We have really strict adherence. We tick off our adherence to each session and all that sort of stuff. And ours, we've got, as you could imagine, the floodgates just opened, and we've just had so many more referrals that there is no way we're ever going to be able to get through everybody. No. We've got 10 going through at the moment. Our waiting list last week was 37. So even I don't anyway. But yeah, so we're opening it up at the start of each module again. But if nobody drops out from module to module, then nobody new starts. So potentially these 37 will not make it in the next 12 months. Yeah.
So the one that the West Moreton group has run at the Gale CCU, which I don't know if anyone's familiar with the area, but it's not hugely accessible to our consumers. It's worked for now because we've just, it's been a sort of trial, work in progress, but it's going to move to Ipswich Health Plaza, which is much more accessible for our consumers. So, hopefully I'll still be able to run something at the CCU, but it will move to Ipswich as well. And
we have our consult group at Floresco, but we have members of the acute care team who are on our consult group. So that's really excellent for our information sharing. We also have joint consult groups between the two of our consult groups. Joint referral meetings where we discuss common referrals, and maybe they could we consider them being case managed? And you could kind of push that along a bit more than what we can. And one of the things that's come out of the West Moreton group is that we've identified the need for a DBT coordinator, because there is some more complex people who do come through the acute care team who don't meet the criteria for case management. So we're looking at that position being a full-time position, and then possibly case managing 3 or 4 very complex people for that period of time over the DBT programme. So fingers crossed that happens soon. We're doing some stuff in the region. We do stuff for BPD Awareness Week, Mental Health Week. We have our MHPN. At Floresco, we also offer Wise Choices, which is ACT for BPD. Essentially, it's an option, I suppose, that we have there for people who are in the less severe end, I suppose, is the way that we're sort of triaging referrals, and ones that are less severe are going down that way. It's been put on pause for the moment while this conference is happening, but we're trying to establish a chapter of the BPD Foundation here in Queensland, and we're involved in that. Our KIMS, Child and Youth Mental Health Service, out at Ipswich runs DBT, and they have concurrent sort of with the kids and the families.
Families, yeah.
And as Sue said before, the park, High Secure, they offer a skills training. So that's a High Secure inpatient unit.
Yeah.
They offer a skills training group.
Yeah.
So there's a few different options for people out in the region currently. And we're going to do even more.
So we're looking at setting up a lived experience support group, so for people with BPD, but then another support group for the families, and that's the family connections training. So one of our clinicians has sort of done some research, and she's got the family connections people coming up from Melbourne to do the training, and Floresco and West Moreton all get together and do that training together.
So we've partnered, the two, Health and Floresco are actually partnered, and we're bringing family connections up here, which is pretty cool.
It's very exciting.
Pretty unheard of. Yeah.
Another thing that we've recognised in the health service is just the stigma, that we're really trying hard to work on. Just a couple of things, the doctors don't really want to give this diagnosis for fear of the stigma, but by not giving the diagnosis, they're then feeding into the stigma. So we've been sort of racking our brains to how to try and sort of not fix it, I don't know if we'll fix it, but certainly work towards better communication and people getting the diagnosis so they can then get the treatment. So one of the things I thought was that we could maybe just do some sort of sneaky training, I don't want to tell anyone how to do their job, but, just do some training on validation skills and the biosocial model. Things like that, so that our clinicians who are burnt out, tired, they're very busy. You saw all the people that go through ED. I just want to help them to understand where this person's coming from, that they're not just another number coming through that you need to send away. We need to help them understand that they're having a rough time and that they need help, and that we can help them access that help. So I'm going to speak to our clinical director, who's very approachable, and see if I can go and do some training at his doctor's meetings. And we're going to also infiltrate the community care teams and just various other places.
The use of language, Sue's language, infiltrate.
Yeah.
Slide in.
But just to try and increase the understanding and compassion, just to give them a little bit. Because, like DBT was, sort of developed, not just for consumers, but, for clinicians who were burnt out and struggling to know what to do. So we can help them. We can tell them what to do.
And we're hoping very soon to have some lower intensity clinical programs at Floresco, so a DBT skills group only. There's up in Toowoomba, which is sort of near here, they offer something, they call it creative coping, which is DBT skills group alone essentially, so we'll probably start that. And we're also collecting lots of information as we go on this, and we're plugging it all in to use it at some point, someday. And it's the first anniversary of our MHPN next month, which is during BPD Awareness Week, and we're hoping to have a consumer come and talk about his journey through the programs, both, in our region.
Yeah. So that's very exciting.
So that's it. Any questions? Oh, we've got two. Do we go to people, or do you go to people?
How about I'm going to get my mic and do the running.
Do you want another one?
Thank you. I'm Betty Ann. I work in one of those community teams you're talking about, that you're going to do validation skills training and things. Can you tell me exactly what you're going to do?
Well, it's just as part of the DBT program, we teach validation skills, and I'm going to do that for our clinicians. So taking some of the DBT skills, taking it out to the teams, and teaching everyone how to do that. So there's, from the DBT workbooks that we would give our consumers, that's what I'm going to do with our clinicians. It's DBT for staff, basically, because as we know, that it's a really powerful way for people to cope, for people to manage, and I think that our clinicians could really benefit from that training as well. Yeah.
Thanks.
Yeah.
Hi, my name's Carolyn Fitzgibbon. I'm from DBT Brisbane. Hi, Melissa.
Hi.
I was just wondering if you could comment on the NDIS and its potential for DBT within the Ipswich region.
When do I get up on my soapbox? Now?
Gosh, yeah.
Yeah. Initially, when NDIS, this is just my personal opinion as a clinician. I'm not representative of the government or Floresco or anything like that, but I know that when the NDIS first rolled out, we were really excited because we thought, excellent, people are going to be able to get funding to be able to access these programs. But my experience of clients is people are being told BPD is not it's not a disability and it's not permanent. So people are being rejected for applications for NDIS. So it's not turning out, so far, what I've seen, to be that at all. So far, and if anyone's had any success stories, that is awesome. I really want to hear them. But unfortunately, I only have stories of, and I've had screaming things on the phone with people from the NDIA in Adelaide making these decisions and trying to explain how it is an impairment and on the different levels of functional impairment and all the different facets, and it hasn't made any difference in the cases that I've seen. So I think there's potential there to be able to use it if people are given access. So far I haven't seen anyone given access for BPD. Correct, that's what it's called. Meeting access means getting NDIS. Yep.
Melissa, in Victoria, we have had success. I'm aware that even in other states, people have been successful getting the NDIS package with a diagnosis of borderline personality disorder. What needs to happen is to focus on the functional aspects of it, less on the diagnosis. And people can be a bit creative with the diagnosis. And complex PTSD is now ICD-11 recognized diagnosis. So, and as you know, BPD comes with all the comorbidities. So it's not consistent. So we are trying to advocate at the national level with the NDIS program so that it's consistent response, because it differs from place to place.
It really does, because
So my suggestion is to ask for a review and appeal again.
a number of my clients are onto their third review already, and I've changed the diagnosis each time. We've got rid of the diagnosis, we've had a different, it just seems to be, in this particular region, I'm not sure what it's about.
It's hard for a lot of different diagnoses in that region.
Yeah, I don't know what it's about. Yeah.
Is it partly whether there's an OT assessment contributing to it or not?
I've had them with and without. But that's just a very small, anecdotal story, obviously, with what I've seen.
It's a big issue, though, in terms of like the broader landscape of BPD and accessing BPD.
Yeah, we had an NDIS local area coordinator come and speak at our MHPN a couple of months ago, where we were asking all these sorts of questions, saying what wording do we need to use, what do we need to, and I even fed that information back to the NDIA in Adelaide, and they said that that's not consistent with what they understand to be, and so I don't know it's just a little bit messy at the moment.
Hello.
Hi.
My name's Kira. I also work for Aftercare, so I guess it's a bit weird, but I don't work in Ipswich. I have in the past, but I work in Meadowbrook at the moment in Logan, and I guess my question to both of you is, what recommendations would you have to, I guess, create the relationship that you have between each other with public and private sectors, and, were there challenges along the way for that?
Oh, a few. I mean, the clinical governance thing was always an issue, but there has been a long-standing service level agreement between Floresco and West Moreton Mental Health Services, and I think that they offer quite a lot of support for people from the mental health unit into community. So, I mean, some of the groundwork was already there. I guess what we were looking at was just sort of a different way of working with consumers in a group setting. So the service level agreements were there already, which I guess was good.
And I think you just have to find, there'll be a couple of people, we've just sort of found there's a core group of people who are super passionate and are willing to, meet outside of work and this and that sort of, just to get some stuff going.
The clinical lead, who I've told you about earlier, who was one of the people who set up the CCU, she's very focused and very driven and just someone who makes things happen. No idea how. She just has these powers, and yeah, she just was really, she had this vision, and now she's got, we've got all these groups. And
So yeah, getting to know people and putting your
Yeah.
face there so people know who you are.
yeah, and meeting up, gosh, most weeks now. So there's
Yep.
weekly communication between all of us. Yeah.
One last question from the back here.
Okay. Well, it's kind of three, actually, if that's okay. Sorry.
We didn't think 30 minutes.
I was just wondering, the 5-day clinician training that you spoke about, was that facilitated by Marshall Lineman, or did you create your own training package? Or
No, it was facilitated by myself and Dr. Sarah Suellen, who's one of my colleagues. She's the DBT Coordinator at the Prince Charles.
Okay.
Yep.
Is there any chance that that's something that you would be happy to share for other regions?
We're happy
to
for
be able
sharing
to-
anything at any time.
That
So
would be
yeah,
brilliant,
the more
okay.
people out there that are aware, the better.
Wonderful, that'd be excellent. And then the other thing I wanted to ask you was, for the 20-week program, were you actually having the participants access those sessions through a mental health care plan? Or
No,
was it
this
fully
is
funded?
This is the only one in Australia that I'm aware of where we are fully funded under. Do you know what the name of the funding is? We're fully funded by the Westmoreton. We're fully funded by the government, essentially.
So the Department of Health.
Yeah.
Yeah.
So Floresco Centre has core staff who are salaried staff, if that makes sense. And so we grab them for 5 or 6 hours a week, and they do the individual sessions and the phone coaching and among their normal jobs. So it's Floresco. So I imagine, under aftercare. So and it's an NGO essentially. People have their own mental health clinician roles, and we just steal them for that many hours per week to do DBT in their normal roles.
Okay, great.
And the Westmoreton one's just the public mental health, so
Yeah.
any consumer can
And can I
access it.
just ask you, because in running the 20-week program, I've found that consumers have given a lot of feedback in regards to the jargon and how unhelpful the jargon within the content of the DBT program by Marshall Lineman is. Have you guys done any rejigging, or you are strictly sticking to
I
the...
wouldn't dare at this point.
Yeah, we stick to it, and just sort of encourage everyone to try and think of things in a different way. Yeah.
Well, thank you, ladies. Can we please show our appreciation?